Okay, so welcome everyone on board. So today we will just have a short discussion about liver because it will take few sessions for us to complete this topic. Actually, um, we started GIT in last week. We just finished some of important points and important tasks which may be asked with reference to gastrointestinal system. So similarly, I will give you an idea, overview of what we need when we are preparing for liver. Okay. So actually, like all our anesthesia medication uh, are metabolized by the liver. Okay. So if there is any problem in the liver, it directly affects our conduct of anesthesia. This is number one. Then there are certain anesthesia medication which can affect liver. There are certain uh, uh, factors which are anesthetic factors which can affect liver. Then there are certain diseases, whether they are acute or chronic, okay, which affects the liver function. So any a chronic liver failure problem or chronic problem can have precipitating acute problem. Okay, but usually it will there will be a differentiation between the factors which cause acute liver failure, and there are factors which has chronic liver problem. This is then whenever there is any problem in the liver, so other system which are directly affected immediately, almost all system will be affected, but cause of the synthetic functions, so coagulation problem will start immediately. Okay, and then low albumin uh, will have effect. We are Because we are just trying to focus what are the things which are related to anesthesia. So even if there is acute change in liver function, it will have immediate sequelae. Of course, the severity will be variable in different conditions. So whenever you are looking at liver functions, so usually there is one synthetic function. Okay, there is one things which are related to hepatocellular damage, and there are third thing which is related to its passage of biliary and tree, and hepatic function is obstructed. So whenever we are thinking about liver problems, usually we consider them in these three categories. Okay. Similarly, like there will be certain symptoms or signs or investigations which we do to quantify whatever the problem is, whether it is acute liver problem or chronic liver problem. There will be certain symptoms, certain signs, and then certain investigations. Okay, so some of the symptoms are sorry, I'm mixing the word symptom and sign. Some of the symptoms will be common one. Okay, so like uh, whether it is related to hepatitis or any synthetic any other problem, usually it will be the non-specific nausea, vomiting, abdominal pain. Okay, and then may more specific problems related to because whenever there will be liver damage and it is leading to portal hypertension. So a number of symptoms or signs will be related to portal hypertension. Okay. Then there will be certain sign symptom which will be related to jaundice. Then there will be certain sign symptoms which will be related to this multisystemic involvement, because it will be affecting lungs. It can affect kidneys. Okay. It can affect heart. So Like there are shuntings, pulmonary shunts. In kidneys, it's hepatorenal syndrome, hepatorenal syndrome. Then it's heart failure. So whenever we are evaluating, usually there will be some non-specific symptoms and there will be some specific symptoms, not on symptoms and signs related to specific liver problem and effects on the different system. So Hassam or Faisal, since you are here, so I will take you on board. Can you just think what are will be the symptoms and signs related to liver problem? Yes.
Sir, abdominal pain, jaundice, vomiting,
Okay. So some of them I have already: nausea, vomiting, abdominal pain, jaundice. What else?
anemia or
Anemia,
bleeding tendency,
ascites.
ascites,
Okay. Hematemesis, melena. Okay. Upper or lower GI bleed. Upper or lower GI bleed. What else? Any other signs and symptoms? Because there are,
Can be also seen in
sorry,
its manifestation.
very good. Problems related to NCAF,
Yes,
NCAF,
hepatic.
encephalopathy. Okay. Because there are traditional words which we have are telling: spider nevi. What else? Palmer erythema. What else? There is one more:
Telangiectasias, gynecomastia.
gynecomastia. Okay.
And testicular atrophy, alopecia.
Testicular atrophy, alopecia. Remember, now there is a trick in the exam, in the Viva. They can ask you reason for anything. So please, better don't tell anything for which you don't know the reason. If you are able to tell the explain the reason, otherwise skip it. Okay, it's better to skip, because if you are telling something and you don't know the reason, like if I'm not wrong, the reason of gynecomastia is a problem in the steroid metabolism. Am I right? Just correct me if I'm wrong. Yes, anyone, please? No one? Okay. What else? Okay. So actually, whatever we do, okay, we will come back to some of the sign symptom if we have if we miss something. So now, after investigations, like acute liver failure, of course, will be a little different. So first of all, we will try to concentrate on chronic liver failure, and usually remember that we classify according to Child-Pugh score. Okay. So whatever pronunciation would you like to say, but our it's like when you are if you have any patient, if they give you a data that certain patient has liver problem, okay, so if you are in table viva, you should just say we will evaluate the severity of liver disease on the basis of history, examination and investigation, and we will classify the severity on the basis of Child-Pugh score. This can be the statement which which will cover everything. And if they want to ask in detail, they can ask you. Okay, because in our part of our part of world, like this hepatitis, viral hepatitis, is one of the cause. Internationally or even hidden in even in our country, alcoholism is more common in West. Okay, and then other certain iron, copper, some other viral infections. We will just have a look on these details. But not only we are evaluating on the basis of history, examination, investigation, and uh, just let me show you the causes of liver failure. Just a second. Mm, just a second. You see, some other causes include, as I told you, viral hepatitis, autoimmune hepatitis, alcoholic liver disease, cryptogenic liver disease, like primary biliary cirrhosis. These will be other causes. Hemochromatosis, like I told you, the copper is Wilson's disease, alpha 1 antitrypsin deficiency, and acute. Among can you tell me among the viral hepatitis, which hepatitis type is uh, culprit for acute liver failure? Can you tell me?
Sir, A and D.
A and E.
A and E, you are missing something. There is C usually cause chronic, but it is also associated with fulminant hepatic failure, hepatitis C. Okay, so don't miss it. Maybe it's not written here, but acute fulminant hepatic failure is associated with hepatitis C as well. Yes, A is common for acute, okay, but it's limiting, like it resolves. But acute this fulminant hepatic
Actually,
failure, if it occurs with hepatitis C, is usually fatal. Okay, so if it happens, so you should be knowing about it. So E in pregnancy. Yes, okay. So because we are dissecting this topic in a slightly different way, can I ask you something that uh, synthetic which function of like which test can detect the earliest at the earliest any liver problem, like among the synthetic function, which function will be deducted at the earliest?
Prothrombin time, sir.
Very good. And what is the reason, like what thing will affect this PT?
So clotting factors are not made,
No,
specifically two
which
seven
one?
nine ten.
No, no,
vitamin
no,
K
Vitamin
dependent.
K dependent.
Vitamin K dependent factors.
no. You are telling, all of you are
Two,
telling
seven.
a non-specific answer. To be specific, which factor?
1, 2, 5, 7, and 10.
Factors.
No, 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 no. It's not
2,
like that.
7, 9, 10.
You
Two,
are
seven,
wrong.
nine.
All of you are just reproducing the book. Please, only one. Hassam, you tell me which clotting factor has the shortest half-life?
Factor 7, sir.
So thank you very much. Why you are telling 2, 7, 9, 10? Okay, be specific. It's the main which is affecting PT is 7. Okay, so
Sir.
don't forget, because this answer is a book. That's why I come out of the book. This answer is a bookish answer. This is not a practical answer. Okay. They will not specific tell you which clotting factor has the shorter this. They will not ask you. They want you to know that factor 7 will be affected at the earliest. Okay. What else will also please Faiza? What else will also affect relatively earlier?
Um, sir, no idea.
How much is
Bilirubin
how?
or albumin, sir, yes.
Okay, so like albumin is also among the earlier one. If I'm not wrong, just correct me because I'm telling you with my existing knowledge. If I do tell you something wrong, please do correct me. Is it albumin or globulin? Somebody wrote globulin. I think globulin has more half-life than albumin. Can someone Google how much is the half-life of albumin? Okay. Okay. So up till now, just a second, please. We have just tried to figure out what are the symptoms, what are the signs, what are the investigations. Now, we will go a little bit in detail about the investigations, but usually it will affect all of platelet numbers can come down. There may be because of bleeding, there may be anemia. Okay, but main factors will be coagulation profile. Okay, any any precipitating cause. You will find some investigation with reference to that one, and I'm not going into at the moment. I'm not going into the organ dysfunction because of liver dysfunction, like hepatorenal syndrome. When it occurs, it is as a result of liver failure, or like encephalopathy occurs, it is as a result of liver failure. Or if there is cardiomyopathy, or if there is like what is called as cirrhotic cardiomyopathy, and if there is this hepatopulmonary syndrome, that is shunting, and there is a very strange sort of thing which occurs 3 weeks. Okay, so globulin is earliest. So I think I'm telling you wrong. So just do correct it that it is half-life of a globulin is for how much time. Anyways, so in liver, sorry, in pulmonary system, what happens in lungs because of shunting? It's pletapnea orthodeoxia. Can can someone tell this difficult word? Do you know about it, Hassam? Hassam has left. Faiza, Iqra,
Sir, I think dyspnea occurs when the patient lie down
okay, and it is because of
because of increase intra-abdominal pressure and then increase intrathoracic.
intrathoracic what? This is dyspnea and hypoxia when sitting upright, okay, which improves on lying flat. I don't exactly uh, know the reason, okay. This is because of shunting. Shunting is more shunting when lying sitting, and when they lie flat, it improves. If anyone can explain, I will be very thankful, because these are only theoretical. Practically, I have never seen this thing. Okay, but theoretically, when they are asking about liver changes, sorry, respiratory changes, so one will be related to ascites, the diaphragm, the simple one, diaphragmatic splinting from ascites, okay, pleural effusions, and also pulmonary hypertension, which can develop because of heart failure. Okay, so these are the things which are separately but this effect is a little bit different. Okay, this effect is a little bit different. Intrapulmonary AV shunting may also occur. Patient may experience dyspnea and hypoxia while when sitting upright, which improves on lying flat. I don't know if anyone know. If you don't know, please have a look. What's the reason exactly? Okay, and
Sir, I
what is
think it
this?
was some type of a diaphragmatic excursion effect underlying this dyspnea on sitting position. I can't
Unfortunately,
recall properly,
though you
but
should know about it.
something happens to the diaphragm.
We will try in our coming days.
Okay,
We will
sir.
try to find out the reason. Do read about it, because this is a question they can ask you. Okay,
Okay, sir.
they can ask you this thing. Okay, so hematological system, anemia may present secondary to chronic blood loss, hypersplenism induced hemolysis, chronic illness, and malnutrition. Reduced capacity to synthesize clotting factor will affect this 2, 7, 9, 10, what you were saying. Okay, and APTT also will be disturbed. Thrombocytopenia, not only platelet function, platelet number will also decrease. Tell me one thing, which clotting factors are not synthesized by the liver?
Protein C, protein S.
Protein C, protein S is clotting factor.
Anti-clotting. Okay.
So please be specific. Von Willebrand is factor, factor 8, and calcium. If I'm not wrong, these three factors are not synthesized by liver. Yes. Okay. What is factor 3? 4 is calcium. What is 3? If you recall. Okay. So in cardiovascular system, what happens in advance? This, as I told you, there is hyperdynamic circulation, there is high cardiac output, and because the vasodilators, which are normally cleared by the liver, are not cleared, so there is low systemic vascular resistance. Okay, and then there is features of cardiomyopathy. Remember one thing, where maybe it is different in etiology, but the presentation, okay, thank you. Tissue thromboplastin factor 3, thank you. So actually etiology may be anyone, but it will be in low cardiac output, and patient will have like high cardiac out, sorry, high cardiac output, but low cardiac ejection fraction. Okay, so it may be in the form of dilated cardiomyopathy. Okay, so the reduced left ventricular workload caused by vasodilatation may mask underlying coronary artery disease and cardiomyopathy. These may become apparent during anesthesia or surgery. Anyways, so these are uh, like okay. So we have covered respiration, we have covered cardiovascular system, hematological system. Okay, so actually hepatic encephalopathy is precipitated usually as a number, there are multifactorial things, but usually if there is, for example, GI bleed, okay, infection, so there is more chances of ammonia production, and anything which is already precipitating the respiratory, like they have mentioned here: infection, gastrointestinal hemorrhage, electrolyte or acid-base disturbance, sedative drugs, hypoglycemia, hypoxia, hypotension, or excessive dietary intake of protein. It will precipitate hepatoencephalopathy. Okay, and hepatoencephalopathy is one of the factor in this one. This child score. Okay, so whenever we are evaluating a patient, okay, there will be I repeat, because I'm giving you a concept, this is not a cramming, because my aim is to clear your concept. So whenever you are evaluating any patient with liver, whether it is acute, whether it is chronic, you will be evaluating first the synthetic functions, any sign symptoms of hepatocellular damage, any problems with reference to obstructive symptoms. Okay, so there will be certain signs, symptoms, there will be certain sign symptoms relative to portal hypertension. Okay, some obvious sign symptoms will be there if it is end stage liver disease. So whatever the things are, you will evaluate, and then you will classify, or you will label it as severe or moderate or mild with reference to Child-Pugh score. We will it will come here. So and then there will be specific sign symptoms related to other organs involved, like we discussed about lungs, like we discussed about heart, we discussed about hematological system, we discussed about nervous system. So in that way, you will say that how is the situation. Okay. So portal hypertension, you should know about forward theory and backward theory about development of portal hypertension. Okay. You see, associated with the development of collateral venous circulation, ascites, and splenomegaly. The presence of gastric and esophageal varices can result in catastrophic GA hemorrhage. Even mild bleeding into the gut may precipitate or worsen encephalopathy. Okay, as digestion of blood grossly increases the bilirubin load presented to the liver. Splenomegaly leads to sequestration of platelets and thrombocytopenia. Massive ascites can raise ICP, intra-abdominal pressure, which affects respiratory renal function. Okay, uh, gastric emptying is also delayed. Risk of aspiration will occur, and H2 receptor antagonists increase blood pressure because they are correlating with us. And then treatment will be of portal hypertension with the beta blocker or this vasopressin, and removing the ascitic fluid. And whenever they are removing the ascitic fluid or iatrogenic, it is removed, patient will suddenly have hypotension. So as we discussed the same thing when we were discussing about this intestinal obstruction, then whenever distended abdomen is deflated, suddenly there will be sudden hypotension. So you have to replace. Specifically here, if you are talking about ascites, if they drain ascitic tap, or if they open the abdomen and suddenly the free fluid is lost, ascitic fluid, patient can have sudden hypotension. So never forget about it. You see, the rapid reduction of intraabdominal after drainage cause marked reduction in CNS pressure, pulmonary capillary wedge pressure, and cardiac output. Plasma volume is reduced because of reaccumulation of ascites, and cardiovascular collapse may happen. That's what I was telling you. So practically, this is because whatever we discuss, we have to correlate it with our anesthesia conduct. Okay. So if there is a liver problem, you have to, there will be two things, as I told you before as well, that there are certain medications which affect the liver function, and there will be effects of hepatic dysfunction on our anesthesia medication. So any like patient will have more sensitivity to the this hypnotic agents, in the sense that patient can have depress CNS depression early, and it can precipitate hepatic encephalopathy. Okay, and like maintenance doses requirement will be reduced, but maybe because of high volume of distribution, maybe they need initially high dose relatively. So you see, uh, but because of the medications which usually are highly protein bound, because of low plasma protein levels, free drug will be more. Okay, so when there will be free drug, the effect will be more. So but any medication which depends on distribution, so initial dose may be requirement may be high, but the subsequent doses will be reduced. Okay. uh, yeah, another point with reference to alcoholism, acute alcohol intake reduce the anesthetic requirement, and chronic alcoholism because of enzyme induction, the requirement will be more. Okay. Dr. Sajid, whenever comes, their mic is on, always. Dr. Sajid never comes. He never speaks, but his mic is always on. I wish that he also speak. Anyways, so neuromuscular blocking, the metabolism of succinyl may be slowed because of reduced pseudocholinesterase. Okay. So pseudocholinesterase concentration is reduced. So there may be prolonged effect of succinylcholine, and resistance to non-depolarizing in patients with liver, which may be due to increased volume of distribution, as I was telling you, and to altered protein binding. Vicronium and rocuronium, both steroid based, have a prolonged elimination phase in severe liver disease. Atracurium and cisatracurium are suitable. And whenever you are using muscle relaxants, you will be carefully titrating through the neuromuscular this stimulation. Okay. Laudanosine, I don't know. It's only theoretical. I don't think so. Practically, we ever see this. That metabolite of both cisteracurium potential seizures. Okay, opioids. Elimination of morphine is delayed in cirrhotic patients due to both reduced hepatic blood flow and extraction ratio. Okay, in patients with associated renal failure, accumulation of active metabolite morphine 6-glucuronide will occur. Morphine is perhaps best avoided in patients. There are two multifactorial reasons why we should not use morphine because of active metabolites. Okay, so more sensitivity. So medications which are metabolized in the blood will be preferred. Like remifentanil will be preferred choice. Fentanyl, if it is given for short time, it will have not much effect. But if you are given in long duration, okay, Fanta will, as this is the problem, fentanyl will accumulate. So if it is accumulate, the elimination half-life is as long as morphine. Okay, so this is very important. And the other fentanyls I have used in my life, all alfentanil and sufentanil, but because we don't use it frequently, we forget. But for MCQs, you should be knowing each effect of each of them. Elimination of alfentanil is reduced in liver disease. Its volume of distribution is increased and protein binding reduced by the lack of alpha-1 glycoprotein. Remifentanil is ideally suited to intraoperative use. Okay. So with reference to opioids, if someone asks morphine, because multifactorial harmful effects, morphine better to be avoided. Fentanyl can be used. Remifentanil is ideal. In our part of world, the nalbuphine, you will not find in the books. But I think nalbuphine can be used in small doses. Doses may be reduced because nalbuphine, you will be surprised when I came to Saudi Arabia and I asked about nalbuphine, they were just looking here and there. What is this? Nobody knows in Saudi Arabia that there is any medication named nalbuphine. Okay, so it's funny. Among the volatile anesthetics, the least metabolism is with desflurane, so that will be an ideal agent. Okay, the maximum metabolism is with halothane, then sevoflurane, then isoflurane. Like you can remember it with the number of 2. Okay, so 20% for halothane, 2% for sevo, 0.2% for iso, and 0.02%. In some books it's written 0.05%, but to just memorize it's like that, around 20%, around 2%, around 0.2%, and less than 0.5% or around 0.02% for desflurane. So desflurane will be better. It also relatively preserves hepatic blood flow, so it has minimal effect on the hepatic arterial buffer response. Okay, so if any patient with positive viral markers, you have to tell that this patient should have occupational health hazards, and the healthcare provider, all the team should be, they will not tell you, but whenever you are discussing about liver disease, you have to tell that if the etiology is of viral hepatitis, communicable disease, so with the, like, either with the pricks or secretions, you have to be careful. Okay, so usually it's with the blood-borne, but hepatitis A, I think, can also be transmitted through secretions. Okay, so you have to be take care about it. Okay, so you see that we have already discussed. We will just malaise, weight loss, dyspepsia, nausea, vomiting, full physical examination will be performed, muscle wasting, spider nevi, pleural effusions, ascites, splenomegaly, and lever of encephalopathy. Okay. So we discussed about investigation, anemia, thrombocytopenia, because this patient will be at prone for infection. Okay. So there is a terminology, if you remember, spontaneous bacterial peritonitis. So this is also because of this tendency for infection. PT is a useful indicator of hepatocellular function and prognostic criteria in liver damage. PT may be elevated, independent of liver function in patients with vitamin K deficiency, DIC, or warfarin therapy. This is other factor. But of course, there will be history if you are taking this. Baseline renal function should be determined, and severe hyponatremia or potassium abnormality corrected before surgery. This is one thing. And baseline renal function is also very important because it will identify between the hepatorenal syndrome, because we will just have a look later on. Because hepatorenal syndrome, the one of the diagnostic criteria is there should be no pre-existing liver kidney problem. Okay. Rapid correction of hyponatremia should be avoided because of significant risk of potentially fatal central pontine myelinosis, and correction of hyponatremia at a rate of less than 10. And another thing is that because here total sodium is not less. Okay, total body sodium is not less. So it is more of dilutional, because there is fluid overload, there is more like it's not uh, hypovolemic hyponatremia, it's hypervolemic hyponatremia. Okay, so things will be a little different. Okay, synthetic liver functions best as a by PT. Albumin also helpful. This is what I was just telling. Elevated bilirubin. Bilirubin, because it will have a number of things, and I don't have very good concept. I'm trying to bring some hematologists on board to find out. I was just making a list of hematological problems associated related to anesthetist. So one of them is this direct, indirect bilirubin, and unconjugated, conjugated Combs test. Because I read so many times and I always forget. Other tests will be cardiac investigation. Remember one thing, it will not be in every patient alike. There may be signs of overload. There will be signs of like heart failure. So in different signs will be there. Non-specific signs will be there in ECG, and then if there is some signs or symptoms, so then you can do some like echo, and echo will tell cardiomap will have show the reduced ejection fraction, and also overloaded state will lead to valvular regurgitation mainly. Okay, and also pulmonary hypertension can also occur. So chest X-ray, ultrasound, lung function test, pulmonary function test, and child Pux score, as we discussed. We There are so many things by which you can remember. I will just share one of the mnemonic which I used to have, this Mr. Bean. Okay. So bilirubin, encephalopathy, albumin, ascites, and N is for nutrition as well, INR. So maybe doesn't you don't like it, but I remember it in that way. So it's common to ask the mortalities as well. Okay, so if it is child's A, it is less than 5%. Moderate child's B, it's 25%, and if it's C, it's more than 50%. So like the sentence which I told you, any patient with liver disease, you have to quantify or classify the severity according to Child-Pugh score, history, examination, investigation, and your aim is to have target the correctable factors to push. If it is C, push to B. If it is B, push to A. And don't let the patient in A go to B, B to C. So this is the answer. If you tell, it is covering everything. And correctable things are what? Correction of infection, correct ascitic tab, correction of albumin, giving FFPs. So these are the things which you can do. Am I right? So that will be the thing which you can do. Okay. So patient will be at risk of aspiration. Patient will have titrated doses of anesthetic medication. Patient will have like you need to do the, like if you want to take CVP or arterial line or anything, punctures, you have to be careful because there will be bleeding tendencies. Okay, even if you are putting NG, be careful because there may be varices. Okay, if you because if you want to do the gastric decompression, if you are putting the NG, it can cause a serious catastrophic problem. So it looks very weird, but in our Pakistan there was one question was asked to a student in a long case about PR, and he forget. He said, I did not do the PR, and he like it was because it's not related to anesthesia, okay? But actually, the thing which he wanted to listen, that even if we want to do PR, it's better avoided, or it should be done if it is strongly indicated, okay? Because abdominal examination is not finished without PR. But in this case, you have to tell that anything which can cause bleeding, you have to avoid. So actually, they just wanted to listen from him that thing, and he unfortunately couldn't pick. So he failed, but this was not the sole reason. He did not. And another thing, remember one thing with reference to history, all other things which we already discussed, one of important thing is history of blood transfusion. Okay, because usually, of course, because of poor socio-economic status and a lot of bad habits, IV drug abusers, or reuse of syringes. Okay, but blood transfusion is also one of the factor of transmission of this viral hepatitis A, B, or C, especially, sorry, B and C. Okay. So, whenever you are taking history for liver, do ask about blood transfusion. Do ask about dental procedures. Do ask about any previous surgeries, because this will have association with and because there are certain types of liver failure in which autoimmune factors are there. So and then you should be knowing the anesthetic, the normal medications which can cause liver damage. Like one of them is anti-epileptics. One of them is this chemotherapeutic agents, okay, immune suppressants. So they can damage the liver. So whenever you are taking the history, you should also taking care of these things, okay. So some of the things we have already, and to avoid further liver damage, okay, you have to avoid hypotension, you have to avoid hypovolemia, you have to have a balanced state. Not, of course, these patients can also go in overload, but hypovolemia will not be tolerated also. So you have to maintain the filling pressures. So that's why you will say, in addition to standard 1 and standard 2 monitoring, you will be doing intra-arterial blood pressure monitoring. You will do cardiac output monitor. You will do urine output monitor. Okay. So as I told you that CVP is not without risk. So esophageal Doppler and T also help, but probe placement is also contraindicated with reference to esophageal varices. So if they want to, you see, esophageal temperature probes, NG tubes, these are all risk. So don't put fingers or lines without care in these patients. Okay. These patients can go in hypoglycemia as well. So you need to do ABGs, as they are telling, ABGs, lactate, glucose, electrolytes, coagulation status. As I tell a number of times that INR, there is also facility of bedside INR, one of the point of care testing, thromboelastography, INR, ACT, you can do for coagulation and platelet functions. Okay, a neuromuscular block and urine output. So these are okay. So okay. So, modified rapid sequence induction, because remember one thing, rocuronium has both uh, renal and hepatic excretion. Okay. Like it is excreted through the bile, it is excreted through the kidneys. So it's not absolutely contraindicated in both of them. And similarly, the Sugammadex, rocuronium, this combo, this is inert, and it's excreted through kidneys. So actually, you can use it in almost every patient. If you have, you can say about risk versus benefit, of course, because in our part of world, Sugammadex is not available in Pakistan. So maybe you are in careful. So always you can say that if it is available. Okay. So we discussed that desflurane is a better choice, remifentanil is a better choice, cisatracurium is a better choice, rapid sequence induction. We talk about monitoring. We talk about electrolyte correction. So these are the things which you should be thinking. Ventilation is controlled to maintain arterial PCO to 4.5 to antibiotic. Large bore IV cannulas is mandatory or should be administered by fluid warming device. This is good anesthesia care. You can tell in any patient, not specific to liver. Don't cram only that it is written in liver. Any good anesthesia care is with warming devices, bear hugger, fluid warmer, and so it's not specific here. Whenever there is any patient in which you need to maintain the fluid volume, you can tell about monitoring of urine output. You can tell about monitoring of arterial blood pressure with stroke volume variation. Okay. Or if possible, if available, cardiac output monitoring. This will tell, this is like you can memorize this answer. Okay. And only when cardiac filling pressure is optimized should vasopressors as such as metarminol and for the treatment of hypertension. Usually, like you have to do to be careful about using these medications. Okay. Okay. Intravascular fluid volume and appropriate cardiovascular management critical to achieve an adequate urine output, because otherwise it can lead to hepatorenal syndrome. The administration, not really hepatorenal syndrome, but because if you don't maintain, because remember one thing, whatever hyperdynamic circulation is there, it tends to go out of circulation. So that's why there is edema. That's why there is ascites. So you have to maintain the intravascular volume. This is important. The word which you have this maintenance of intravascular fluid volume. Okay, because otherwise the fluid dynamics will not be maintained if you don't maintain. Okay. Crystallite solution may be less effective than colloids in the presence of ascites, but a background infusion of 5 to 10% dextrose. And remember one thing, don't tell as a default. Just tell that these patients may be at risk of hypoglycemia. So you have to monitor the blood sugar, and if needed, you can give dextrose. Don't tell that a background, don't reproduce these words. These are the failure points. If you reproduce without thinking words like this that I read from article, so this article can destroy you. These are the things to just make up your concept. Okay, I hope you understand. Don't tell anything openly. Another thing now, because of analgesia, because if you give paracetamol, paracetamol is not contraindicated fully. Okay, you can give in reduced dose. And NSAID, because of risk of bleeding, this is another controversial thing, and also nephrotoxicity as they written. You see, is not contraindicated but should be used with care. Okay, so you can say carefully given relatively smaller dose, and then any deep block is no block without ultrasound. Tab block, because tab block is relatively superficial block, so you can give because it's just, but otherwise fentanyl PCA you can tell if it is available. Fentanyl PCA you can tell about it, and some of the superficial blocks maybe you can give. Okay. So this patient, your post-operative care will be with reference to prevention of patient going in encephalopathy, patient at risk of bleeding. So it depends on which surgery patient is going, because there will be certain procedures related to that we already discussed in our previous discussions about ERCP, upper GI bleed, colonoscopy. Like there are certain things which these patients will be at prone to develop, prone to have. But liver patient can come for any surgery, emergency. Usually elective surgeries will not be done. Okay, and then they can ask you about liver transplant. So we covered some of the points with reference to this article. Let's go to another. Just a second, please. Try to see anything. Anyone wants to add something, please, because I will just finish here. Yes, Faiza. So the people who are going for long case, I've just explained in a very simple way that if you see a patient with big liver, remember one thing, that you have to step by step rule out everything. Okay, and your questions should be methodical, and like there will be certain journal points and then specific points. I think we have discussed almost all the things, and in our preceding discussions we will just try to explore some further topics related to liver. Okay, please do come with any questions and any suggestions about our discussion, because the purpose of our sessions is not to give you specific facts. It is to clear your concepts, because facts are written in the books, but sometimes you don't have uh, like good concept, and then you are stuck. So as a rule, don't use the word which you don't know the next step in the oral part, especially. And for MCQs, try to find out the specific reason, because in MCQs, even the smallest minor points they can ask you. But in oral part, you need to have a very clear concept. Okay. So we will just continue our discussion on liver in coming days, inshallah. So thanks a lot. I gave a conceptual discussion, and please do read about it. And yes, one more thing I just want to show you. Uh, just a second, please. As this link I share in the all, whenever you receive the this Google, sorry, this Zoom meeting, there is a link in it. Okay, so if you open this link, you will find these further sub, sorry, see. So you will find some questions which I have prepared, a number of things. I am a one-man show. I just try to invest my time in positive way. Do have a look on these questions, and we will just try to find out. Like, I am not very good in understanding, and I'm studying this thing last 20 years. I never understand. So please, and I have read a number of time shunting. I don't only remember this is because of shunting, but I would be very happy if someone explain how this happens, because in the exam they can ask you. Okay, so there are certain questions which I have just tried to uh, compile here, so you can have a look here, and we will just try to find out the answers. Okay. So thanks a lot, all of you, especially friends from our colleagues from other country. It's been an honor for me as a Pakistani doctor to have all of you on board. So just spread the message, and remember one thing. If you know only one word, please teach others. Okay, because this is the message which I give to all of us, that day of our life, when we wake up in the morning and we sleep, finish our day without teaching or without learning anything, that day of life is lost. Okay, so try to teach, try to learn every day, because every day is a new day, and every day is a new horizon to learn and teach. Okay, so thank you very much, and inshallah we will meet tomorrow. Bye bye.